Hello everyone, my name is Dr. Zainab Vora and I am your mentor on the Unacademy platform. We are beginning a new series on YouTube which is called Image-Based Questions, and this is the first episode of this particular series. Here we'll be looking at multiple clinical vignettes which will have a supporting image, and either you'll be asked the diagnosis or further management. Alright, so let's begin. Before that, I'd just like to introduce you to the platform which is Unacademy. So it is an online learning platform, guys, where you have live classes with educators through all the 19 subjects. So this is very, very useful, not just for cracking PG, but also to form, very, very good foundation and very good concepts for your MBBS professional exams as well. In case you are interested in getting the subscription, guys, for a plus program. What is a plus program? So plus subscription is something where you get an in-depth analysis of all the subjects. So there is in-depth coverage of all the 19 subjects by various educators. Alright, so in case you want to subscribe for it, guys, you can use this code, which is ZVORA, in order to get a 10% off on the subscription, guys. So use the code ZVORA in order to get the subscription. So those of you who have not yet checked out the platform, guys, I urge you to just visit the website or download the app on your phone and check out the free classes. So there are a lot of free classes by various educators, including myself, where you get to have a brief trailer, or basically a taste of what the platform or what live interaction would be like. So please check out those classes. Those are completely free of cost, and you can get a lot of information out of that as well. Alright, so now let's begin with our question of the day, which is a 20-year-old male who presents to you with refractory focal temporal epilepsy with this particular MR image, and what is the likely diagnosis? So first, very briefly, let's just focus our attention to this image before we look at the options. So this, as I have told you, is an MRI. If I had not given you this information, how do we distinguish it from CT? So most often students have a problem in distinguishing CT and MR at undergraduate level, right? So remember, guys, remember this thumb rule that always in CT the bones will appear white, whereas MRI the bones should appear black. Particularly the cortical bone should appear black. So if we look at the calvarium right here, the skull bone right here, it's black, and the thin white outline that you're seeing is the subcutaneous fat. Now do not confuse the fat with the bone, guys. Alright, so remember the thin outer rim is the subcutaneous fat, whereas the black thick calvarium is nothing but the cortical bone, and hence this is an image of MRI. Alright, now once we know the modality, we have to focus on the plane. So it can either be an axial plane, a sagittal plane, or a coronal plane. Alright, so remember in CT and MR both, because they are cross-sectional imaging modalities, you can have images which are there in all of these three planes. Alright, so this right here is a coronal plane. Alright, so remember this is a coronal T2 that I am giving you. Now, how do I know it's a T2 weighted sequence? So on MRI, guys, the basic sequences that we need to know are T1, T2 and flare. Alright, I have talked about this in very much detail, guys, in my series on basic concepts. So if you just go to the Unacademy app, to my profile, you will find multiple free classes that I have taken covering basic concepts of various imaging modalities. Alright, so I urge you all to please check out that series. That's completely free. I've talked about X-ray, fluoroscopy, CT, MR, mammography, nuclear medicine, all of these in a lot of detail, and that will definitely be helpful for cracking PG entrances. Alright, so coming back here, so this is nothing but a coronal T2 weighted image, and how do we know it's T2? We always look at the CSF, guys. So the fluid or the CSF, if it appears white, it is a T2 weighted sequence. So if we look here, we look at the ventricles, basically the lateral ventricles, the temporal horn, the third ventricle, the sulcal spaces. So there's a sylvian cistern, all of there, the CSF is white. Hence we know that this is a T2 weighted image. Correct. So now this is a T2 weighted coronal section. Let me just give you a hint. I have taken this coronal section to the level of the hippocampus. Alright, now let's look at the options and let's see what is the likely diagnosis or the pathology that is shown in this particular image. The option A, tuberous sclerosis, mesial temporal sclerosis, Dnet or dysplastic neuroepithelial tumor, and cavernoma. So these are the four options. I'm going to just give you a few seconds in order to think over it. If you are attending the premiere, you can just type it in the live chat what you think the answer is. So try and guess the pathology in this particular image, guys. So the correct answer here is MTS, which is mesial temporal sclerosis. Alright, so I'm going to talk about this in detail, and we'll also look at the options in detail. Alright, so temporal lobe epilepsy, remember guys, is the most common area where we have partial complex epilepsy. Alright, so this is one-liner question for you, where temporal lobe epilepsy remains the most common form of partial complex epilepsy. Amongst the temporal lobe epilepsy, guys, remember MTS is the most common cause. So mesial temporal sclerosis that we are talking about today is the most common cause of temporal lobe epilepsy. Very, very important one-liner, guys. Alright. Now, briefly to tell you about the demographics, so remember it tends to affect young adults. Alright, it tends to affect young adults in their 20s and 30s. And there is no sex predilection as such. Alright, then talking about etiology. So etiology remains unknown. Alright guys, there is no clear explanation of the pathophysiology behind the sclerosis of the mesial temporal lobe. But the proposed hypothesis is something which suggests that there might be an early ischemic insult. Alright, so early in the gestation or early in the childhood, there might be some ischemic insult which results in the sclerosis of the mesial temporal lobe. Alright, so I'm constantly saying the term mesial temporal lobe. So remember guys, the area which is predominantly affected here is nothing but the hippocampus. Alright, it's the area which is hippocampus which is predominantly affected here. Just sorry for this lag with the pen. Alright, so the hippocampus, remember guys, it's shaped like a seahorse. So literally the term hippocampus means seahorse. I'll be showing you a few images and you'll know that it looks like a seahorse, hence the name hippocampus. Now, various authors have suggested various parts of the hippocampus, but remember the predominant part, or the hippocampus proper basically as it's called, is the Ammon's horn. So again, Ammon is a Greek god behind whose name we have the Ammon's horn, alright, which is called the hippocampus. Alright, so this is the hippocampus proper, which is the Ammon's horn, and again, histologically we divide this into various parts, alright, which are called CA 1 to 4. So we have CA 1, 2, 3 and 4 areas, which are just a histopathological division of this Ammon's horn. What does CA stand for? So that's nothing but Cornua ammonis, which is nothing but the Latin version of Ammon's horn, right? So we have CA 1 to 4. Now remember this area, again an important question from you from anatomy guys. CA1 is the area which is most sensitive to ischemia. Alright, so remember one very important one-liner that can be asked to you, which is the area of hippocampus that is most sensitive to ischemic insult. Remember the area is CA1, and that is why CA1 also happens to be the most common area to be affected in MTS. Alright guys, so very important, one is the area most sensitive to ischemia, happens to be most involved in MTS. That is why ischemic insult is the most commonly accepted hypothesis for the occurrence of MTS. So with that brief, again, what about the sites which are affected? So this was histopathologically correct. So grossly we have the hippocampus that is divided into the body, tail and head. Alright, out of that the body is the area which is most commonly affected, followed by tail, followed by head. So again, a question that can be put to you as a one-liner in another form. Now, what about the laterality? So remember, 85% of the cases of MTS will be unilateral. Alright, so remember, majority of the cases are unilateral. And a lot of times, coming to the treatment, a lot of times these cases are refractory to anti-epileptics, and those patients respond very, very well to the surgery which is anteromedial temporal lobectomy. So remember, the treatment for refractory seizures would be surgery, and the patients respond very well. Alright, so the treatment of choice for surgery would be anteromedial temporal lobectomy. With that background, let's briefly look at the radiologic correlation with the anatomy. First, I'm going to show you the normal appearance on MRI, and then we'll understand the pathology much better. So let's look at this schematic right here, guys. So this is a schematic diagram which is nothing but a coronal section that has been taken through the hippocampus. Alright, so I'm showing you a brief schematic of the coronal section of this particular area. So remember guys, the hippocampus is formed by the interdigitation of two U-shaped grey matter. So if you can just see this, so there are two U-shaped grey matter cortices which will interdigitate to form this particular structure. Can you see how it looks like a seahorse? Hence the name hippocampus. Alright, so the two cortices guys that we have, is the dentate gyrus right here, and the other one, as we discussed, is the hippocampus proper or the Ammon's horn. Alright, so these are the two grey matter cortices, U-shaped cortices, which interdigitate with each other. Alright, and this particular area, guys, very important, is nothing but the temporal horn of the lateral ventricle. Alright, so this is the temporal horn. You'll understand the significance of the temporal horn once we look at the pathology. The temporal horn dilatation, remember, becomes very important feature when we want to look at the atrophy of this area. So you can just imagine, if this is normal, we should have only this much of temporal horn. If this were to undergo atrophy because of the sclerosis, which is the pathology, the temporal horn would become widened. Right, so that is one of the very useful features that we use for imaging of MTS. Okay, so with that background, so this is the brief anatomy of this particular region. This particular sulcus right here is the hippocampal sulcus, and this is the parahippocampal gyrus. Alright, and this sulcus right here is the collateral sulcus. Okay, so this is just a brief anatomy of this particular area. Now let's look at the imaging finding. So again, I am showing you two T2 weighted MRI images. This is a sagittal image, as you can see. It's a sagittal image that has been taken, not in the midline, a bit lateral to the midline. So this is the area of the hippocampus, guys. So this is the head, this is the body, this is the tail. Alright. So now remember, guys, whenever I want to diagnose MTS, it won't be done on a vertical coronal section. Usually, what do we mean by coronal? It is a straight perpendicular section through the brain, correct? But remember that the anatomy, this particular anatomy appears best when I take an oblique section. Alright, can you see that this is the section how it's taken? It's taken in an oblique manner. So remember, the plane of choice, if they ask you, will be a coronal oblique. Alright, so the coronal oblique MRI image will be most useful in diagnosis of MTS. Is that correct? Is that understood? So this is what it will look like. Once I take an oblique section through here, this is what it's going to look like. So these are the two hippocampus that I can see here, or hippocampi that I can see here. So this is again the right side, this is the left side. Again, those of you who are juniors, remember, whenever I look at any radiological modality, I assume that it's a person standing opposite to me, and this will be the right and this will be the left. This holds true for all kinds of CT, MR, X-rays, alright, unless mentioned otherwise where the patient is prone. Alright, so normal circumstances, not anything mentioned. Remember, this will be right, this will be left. Alright, so you have this right hippocampus and the left hippocampus. The white area that you see here is nothing but what? It's the temporal horn of lateral ventricle, correct, that we saw here. And this, remember this particular interdigitations are normally seen. These undulations or these interdigitations or these lobulations should normally be seen. And a loss of these interdigitations is also one of the features that occurs early on in the stages of hippocampal sclerosis. Alright, so this is what normal hippocampus should look like. With this background of the anatomy, guys, let's look at the pathology. This is something that you need to identify. So remember, as we discussed, 85% of the time it's going to be unilateral involvement. So we always have the opposite side to compare, alright, and then the pathology would stand out, alright. So remember, in your exam, they will not give you either bilateral cases or very subtle cases. They'll give you marked atrophy like the one that is seen here. So if you compare it with the normal side itself, if you just compare the symmetricity of this image, you know that this is where the pathology lies. Here we have something which is not there here. So here is likely the localization of the pathology. So that is how you approach any image based question. Alright, particularly in radiology, try and look for symmetry on the two sides, and that will help you narrow down the area of the pathology. I hope that makes sense. Alright, so with that, let's look at the MRI features. So we have a triad of MRI features which is very important for you to know. So first will be, because of the sclerosis, they will undergo atrophy. So the hippocampus undergoes atrophy, resulting in a decreased volume. So if you see here, if this is the volume of the hippocampus right here, it's completely atrophied. So decreased volume. T2 flare hyperintensity. Again, early sign where you see that because of the ischemic insult or because of the pathology, we will have hyperintensity. So remember, again, a basic concept that T2 hyperintensity is a marker of almost all kinds of pathologies. Alright, and that is better appreciated on flare sequences. What are flare sequences? Please again see the basic concept class, just a reminder. So flare is a sequence where I suppress the fluid, in the ventricles, in the sulcal spaces, such that the pathology ka T2 hyperintensity stands out. Okay, so in order to better pick up, to increase the sensitivity of picking up this T2 hyperintensity, I do the sequence which is called FLAIR, which stands for Fluid Attenuated Inversion Recovery. Don't need to know the full form, but just know it's again a T2 weighted sequence only, but I suppress the fluid inside the ventricles, inside the sulcal spaces. Alright, so T2 hyperintensity will be a feature of MTS, and the third feature, as I already discussed, will be an enlarged temporal horn, secondary again to this particular atrophy. Alright, and one more early sign that I told you was the loss of the normal undulations or the interdigitations that would be seen in the hippocampus. So I hope this is clear. I hope you will be able to recognize the pathology. This is very, very important. This is a potential question that can be asked to you. Now, just to give you one extra edge pointer. So remember, there is a modality, there is an advance in MRI which is called T2 relaxometry. So this is nothing but a quantitative measure. Alright, so if I want to quantitatively measure how much is the hyperintensity or the T2 relaxation, I can do that with the help of T2 relaxometry, and this becomes more sensitive. Alright, so I don't have to wait for this atrophy to occur. I can pick up this disease much more earlier with T2 relaxometry, where I measure the T2 relaxation, alright, where I measure the amount of T2 hyperintensity. So it's a quantitative, more reproducible technique and more sensitive as well. Alright, so just one extra edge feature for you. So I hope you have understood how to recognize MTS. Now let's talk about the different options that we had. So if we go back to the question, we had three other options. Now briefly, I just want you to introduce you all to these three entities basically. Tuberous sclerosis, again I have done one entire free class guys on syndromes, which are neurocutaneous syndromes, again a favorite of examiners. So we have looked at all the images of all the syndromes. So here let's talk about tuberous sclerosis. So again, a neurocutaneous syndrome involves multiple organs. We have tuberin and hamartin, which are the genes which are involved in TSC, and the chromosomes involved are chromosome 9 and 16. Alright, so that is tuberous sclerosis. Now let's look at a few cardinal features. So again, I'm showing you this MRI of the brain, and this is the FLAIR sequence that I was talking about. So what we are seeing here, guys, the pathognomic feature of tuberous sclerosis on MRI brain will be these multiple subependymal nodules. So can you all see these multiple nodular deposits in the subependymal location of the ventricles? So remember, this is the hallmark of tuberous sclerosis on imaging, where we see subependymal nodules. Rarely what can happen is one of them can enlarge, typically at the foramen of Monro, and this particular entity is called SEGA, which is a subependymal giant cell astrocytoma. So remember, subependymal giant cell astrocytoma, again associated with TSC, and the typical location is at foramen of Monro. Apart from that, the other important finding from where the name derives, which is tuberous sclerosis, are the cortical tubers. So these are nothing but hamartomas. Alright, so remember, because the genes tuberin and hamartin are mutated, we have multiple hamartomas throughout the body which develop. So these are the cortical tubers, which are nothing but potato-like enlargement tubers. So it becomes diffusely enlarged to resemble tubers basically on gross examination. So this is this hamartomatous cortical proliferation that you are seeing. And a lot of times there may be white matter abnormalities which are called radial white matter lines. Alright, so radial white matter lines are also a feature which is included in the minor criteria of TSC. Remember, cortical subependymal nodules, SEGA and cortical tubers are all major features. Okay, just one more thing for you for tuberous sclerosis. We have the typical Vokes triad, as I have already talked about in my class. What does Vokes triad stand for? So earlier it used to be called as epiloia. So we have epilepsy, low IQ and adenoma sebaceum. So remember, adenoma sebaceum will be acne-like lesions near the nose, near the bridge of the nose. Alright, so these three form the Vokes triad. Now coming back to this CT. So again, I am showing you this HRCT. I have talked about the basics as I have already told you many times. So basic concept के classes में we have talked about how to recognize high resolution CT. So this is HRCT of the lung or the lung window of a CT, where I am seeing these multiple cystic lesions in the lung. So these are cysts in the lung which represent pathologically LAM, and LAM stands for lymphangio leiomyomatosis. Let me just write that for you. So it's again a hematomatous growth, which is lymphangial leiomyomatosis. Alright, so again this is very typical of tuberous sclerosis, where you have multiple well-defined cystic lesions and the background lung remains normal. Alright, now what about this? Again, I am showing you a CCT of the abdomen now. I am showing you a CCT. How to identify it? The vessels, the kidneys appear white. So it's a contrast enhanced CT. If you look at the bones appear white. Hence we know it's a CT that we're talking about. Now here in the kidney I am seeing a lesion. I am seeing a pathological lesion which is predominantly consisting of fat. Again, how to recognize this? I have talked about it a lot of times. So this is nothing but a angiomyolipoma. Now it has lipoma in it, it has angiomyolipoma, again a hematoma basically. So you have lipoma component which attributes this blackness to it. Alright, so you see the subcutaneous fat ka black, you see the black here. That is how you know that it has fat in the basically the pathology has fat in it. And if I want to quantitate it, basically I can use ROI, which measures the Hounsfield unit, and the Hounsfield unit will be negative. So remember, fat and air are the two things which have a negative HU. Alright, so this, coming back to it, is an angiomyolipoma, which is again a pathognomic feature of tuberous sclerosis. So all of this entity represents TSC, and this is the kind of brain image that would have been given to you. Alright, so remember, they, as the term epi suggests, they also have higher predisposition to seizures. But remember, one, it won't be temporal lobe seizures, and secondly, you will see these tubers and the pathognomic features that I have discussed with you. Briefly talking about the other two options. We have Dnet. So remember, dysplastic neuroepithelial tumor is a neuronal tumor. It's a tumor of neuronal origin, which again tends to cause temporal lobe epilepsy. It is one of the causes of temporal lobe epilepsy, but it will appear like a T2 hyperintense lesion. Alright, it will look like a T2 hyperintense bubbly lesion is the typical description that is used for it. Alright, so this is what it will look like. Here we cannot see any sort of tumor. In fact, we are seeing hippocampal atrophy. So that is how you distinguish this. Cavernoma again is a hematomatous growth of blood vessels basically. Alright, so it's a benign lesion where you have blood vessel ka growth, and what you will see is a very dark lesion. You will see a completely dark lesion because it has blood accumulated within it, which causes susceptibility. Alright, it causes an artifact which is called susceptibility artifact, because of which it appears black. And remember, the imaging sequence of choice on MR will be this image, which is susceptibility weighted imaging, which will be very sensitive to pick up any sort of hemorrhage or blood accumulation. Alright, so remember, we will do SWI for cavernoma. Just one additional extra edge pointer for you. We have a classification for cavernoma which is called the Zabransky classification. Alright, so just one extra edge pointer for you. We have the Zabransky classification for cavernoma. Again, remember, cavernoma can also predispose the patient to have multiple seizures. Alright, so that's it guys for this particular series. Look out for more such questions. I'll be bringing up a lot of such image-based clinical scenarios where we can integrate a lot of facts, whereas it's just anatomy integration and integration of clinical findings as well as the imaging findings. So I hope you like this class. I'll see you all in the next episode. Thank you guys. Bye-bye.